Good evening, everyone. Lucas Marchand here, coming to you guys with another installment of AO North America Link Unlocking Orthopedics Season 3. In our fourth session tonight, we're going to be talking about research as a medical student and how you can become successful doing this. So, a lot of this lecture, at least the early two-thirds of this lecture, is really going to focus on what research is, why it's important, and then finally, once you have the context of what it is, why it's important, we'll talk about how you can succeed. As a reminder, please stay in tune with us in our joint collaboration between AO North America and MSOS for case-based learning every Friday. Fracture Friday releases short case-based educational videos that we hope you will find valuable each week. Don't forget to become an AO member using the QR code listed on this slide. As a reminder, AO North America Link is a medical student-based education platform. We are coming to medical students for your education in what we believe to be a very unique forum and something focused solely at orthopedic-based medical student education. Dr. Kellum and myself have really went a long way to try to make this curriculum relevant and pertinent to your all's education. We certainly value you guys joining the lecture tonight and also watching these on replay. Please spread the word to other medical students at your institution and abroad when you're on visiting student rotations. We appreciate you getting the word out so we can impact as many lives as possible. We'd like to take a brief moment to thank the AO North America leadership for supporting this mission and a specific acknowledgement of Dr. Timothy Aker, who is the founder of this Link initiative. So for tonight, you'll have co-chairs, myself, Dr. Lucas Marchand, and Dr. Patrick Kellum. And joining us is past AO Link chairman Phil Mitchell, and Aresh Sefri. Joining us from Vancouver, the University of British Columbia. He is an excellent researcher who was actually just awarded a NIH grant. So kudos to Aresh. I'm happy to be able to say that. And we're all grateful that he'll join us tonight and share some of his expertise and why he thinks research is important, its value in clinical care, in sort of the role that you all may play as a medical student in the design, execution, and even potentially the dissemination of research. Here's a look at the disclosures for both chairs tonight, myself and Dr. Kellum. As a reminder of where we're at in this third installment of AO Link, we are on the fourth lecture. In October, we're going to go until April of 2026, so we're almost halfway through. Please join us next month for a residency interview session where we'll hopefully be pointing out some very important parts of being successful when you're on your residency interviews. And feel free to look back if you've missed any of the previous three lectures. Feel free to go back through the archives and watch those. Don't forget about AO Milestones. This is an individualized learning experience ran through AO Trauma, which you can sign up for using this QR code. I'll remind you of etiquette. Please have your microphones muted. Please send all questions or technical issues to the QA box. The moderators will review and sort questions as they appear. The chat box is just for faculty to communicate, so please leave that for us. Don't forget to earn a merit badge in fracture management by reviewing the lecture tonight and signing up through this QR code. If you earn Credly badges for all of the sessions through the third installment of AO Link, there is going to likely be a reward for you at the end. So let's delve into research as a medical student. How can I succeed? As an overview here, we're going to talk about why research, why is evidence-based medicine, which is driven by research, what is evidence-based medicine and why does it matter? And finally, how can I succeed at research? And I'll tell you that a bulk of this lecture really is going to be discussing why I, Pat, Phil, and Aresh do research, and then a brief overview of what evidence-based medicine is. This is an idea you all have probably already been exposed to in medical school, but I think it's important to revisit the idea because to really succeed at executing research, I think you have to know why you're doing it or have a why, like many things in life, and understand why it matters or what it's used for. So let's build upon that framework to figure out how we can succeed. So, why research? I'm just going to take a second here to give you all kind of my personal anecdote when it comes to research. So, this is a meaningless slide if you're just looking at it, but if I give you a little bit of context, hopefully I can make it make sense to you all. Most of life and most of questions in medicine are live somewhere in the gray. That is to say, there's not always a clear right or wrong answer. But I am at my core a black and white person, and I live in the black and white essentially. So I'm always trying to eliminate the gray, meaning I'm trying to always find the right answer. And in medicine, research is one way that we can come to at least eliminate some of the gray or to come into a very clear black or white picture where there is definitely a right or wrong answer. And that is part for me of the value of research is that as I'm navigating a clinical dilemma throughout my workday, I rely heavily on clinical research to help me decide what the best treatment option is. That is to say, to move away from the gray and into the black or the white. And we'll start with a case, as we have for many of the lectures in this series to date. Your page to help in room 24 about a 71-year-old female who sustained a ground level fall and presents to the emergency department with right hip pain. She's on apixaban and she has a history of heart failure. And you see these plain film radiographs, which demonstrate a standard obliquity intertrochanteric femur fracture with posterior medial comminution and a thin lateral wall. That is all to say an unstable intertrochanteric femur fracture. And I guess I would ask Aresh tonight, when he sees this x-ray, in what way does research impact the manner in which he may care for this patient?
Yeah, the case of a hip fracture is very interesting because it's such a common orthopedic trauma injury that there's actually a lot of quality evidence. So a lot of our randomized controlled trials published in New England Journal of Medicine, Lancet, are on the hip fracture population. And so going back to your black, white, gray analogy, a lot of the questions, there are kind of black and white answers to the point where the evidence now is being incorporated into clinical practice guidelines. Having said that, as we continue to try to improve patient care, there's a lot of questions still out there that we don't quite know the answer to, or in fact, practice has actually changed from my time as a resident to staff now.
Absolutely. And you bring up some great points that we're going to revisit later in the lecture when you're talking about the quality of evidence. Because hip fractures are so common and they are such a public health issue, meaning they impact a large portion or a large percentage of the general population, we're able to execute high quality studies that give us high quality evidence that really help us move out of the gray into the black and white. Pat, what are some of the questions that come to your mind when you see an injury like this? Like when you're thinking through the care pathway for this patient, you're coming to crossroads, right? Like what crossroads do you come to, or clinical questions do you have when you're managing a patient with this injury?
Yeah, I mean, I think there's so many, and you think it's so simple of, oh, it's a hip fracture. We're just going to take it to the OR and put a nail in. Even that has come from a lot of research that's shown that some of the cephalomedullary nails that we use today are better for patients like this with a thin lateral wall. So a lot of the things we say so quickly at sign out have really come from questions that the people before us answered because they had clinical questions about what was best to do. So for me, it's When should I take the patient to the operating room? Does this patient need a workup? If their troponins are high, is this a good thing, or is this obviously not a good thing, but do I need to worry about that or not? Um, is their blood thinner something that's going to get in the way of me doing surgery? Do I need to wait for their blood thinner to go through 5 half-lives so that I don't lose a lot of blood? What do I do post-operatively? Can they be weight bearing as tolerated? When do I see them in clinic? What about how do I close their wounds? Is there wound dressings I need? These are all things going through your mind when you're doing a surgery that you can kind of, when you do it enough, you can think through it quickly, but these are all very simple questions, that have very complex answers that a lot of them have been shaped by research.
So Pat hit on a bunch of important clinical questions, and he certainly didn't cover all of them, meaning he didn't cover every single crossroads you'll come to in a clinical care pathway for this patient. But a couple of them he mentioned I had also put in this presentation. So, how soon does surgery need to be performed? What do I do about the apixaban? Like Pat said, do you need to wait for 5 half-lives of the apixaban in terms of timing of performing surgical intervention? Does the patient need an echocardiogram? They have a history of heart failure. Does that provide any value or care improvement for this patient? What type of anesthetic should the patient receive? Is it general anesthetic perfectly fine, or would a spinal be better? What medications will the patient need intraoperatively? Do I need to give them antibiotics prophylactically? What about tranexamic acid, which has been shown to potentially decrease blood loss for these patients? What should I use to prep the patient's surgical site? I always find that people chuckle when there's a question about what you use to prep the patient's skin. But I would say, up until very recently, this was something that was debated and everybody had their own preference, and there wasn't really data to guide us in this realm. What bed should I use to fix this fracture? If we think back to 1 month ago when we talked about surgical implants, we did a quick review of the different type of beds that fracture surgery is performed on. You have standard radiolucent beds, or what we would call like an OSI flat top bed, which is very universally used, or you have specific fracture tables or traction tables, beds that themselves are able to per perform or apply traction to an extremity. Is one or the other of those bed types better for this patient? And what implants work best for this injury? Is it a sliding hip screw, or something you all may have heard called a DHS, dynamic hip screw? Or is it an intermedullary implant like a cephalomedullary nail? And if it's a cephalomedullary nail, is it a cephalomedullary nail that just has one screw that goes into the femoral head, or is a two-screw implant better? And how should I close this wound? This is something that Pat brought up at the very end. These are all questions that surgeons that are many years into practice reflexively answer in their head without necessarily explaining out loud. But the reason they're able to reflexively answer many of these questions in their head is because they're well versed in the literature and the evidence, and they're practicing evidence-based medicine. So, before we talk about what the answer to some of those questions are, or how evidence may guide you to answer those questions, it's important for us to understand what research is. And so I guess I'd open it up to Pat quickly to get his definition of research, or maybe a better way of asking this, Pat, is like, what does research mean to you?
Yeah, I think on a very basic level, research to me is taking being able to answer a question with the available clinical data that you have. I think you're going to touch on it in a little bit, but a lot of what this presentation is on is clinical research, but it's being able to better understand the inadequacies of our knowledge, I think is what I would call research.
Aresh, does your definition or opinion of what research is differ from that much?
No, I think Pat hit it right on the head in terms of the goal of research is to define a clinical dilemma and then find a way to answer it. so that we can improve our patient care. And I guess the fun part about research is how are we going to answer that question? And that's where all the interdisciplinary teamwork and everything comes in.
Which is an excellent segue into our future slides. So, Pat and Aresh did an excellent job of answering what is research. If you want to get to a very technical definition of research, it's a systematic collection of information to help us learn more about a phenomenon or treatment. Specifically, we're going to focus on clinical treatment or clinical phenomenon tonight because that is the area of research that I most commonly use in my practice, as well as Pat and Aresh. And it's also the area I would consider myself the most well versed in. Not necessarily an expert by any means, but it's the type of research that I both do read, review, and critically appraise. So, research is a branch of medical science, and it, in the end, is there to help us determine the safety and effectiveness of medications, devices, diagnostic products, treatment regimens, anything that's used or intended to help human beings. That is really clinical research. And then, like I said, good segue. Aresh talked about the really interesting thing is how do you do good research? Well, you do good research by identifying a clinical problem. So there are thousands of those that we encounter every day that still haven't been answered. But when you identify that problem, you still have to ask the right or the correct question because just identifying a problem but asking the wrong question, and there are many examples of this in orthopedic literature where the authors had a great clinical problem, but they didn't quite ask the right question. And so you read the paper, the manuscript, you get to the conclusion, and you're left thinking, I really wish they would have done that because that's really the crux of the problem that I was interested in. And then when you ask the right question, you can define and apply the best methodology to answer that question, and then hopefully interpret the results in a correct way. Why do research? And while I kind of, when I was talking to Pat and Aresh and Phil about making this PowerPoint and giving this lecture tonight, I told them that we were going to kind of get into a little bit of the touchy-feely side of medicine because I don't really think you can talk about research without talking about why you do it. And for many people, this is sort of a touchy-feely subject. So we're going to enter that portion of the lecture for a couple minutes here, and I'm going to ask Aresh to tell me why he does research.
I think for me, early on my residency, OTA, the Orthopedic Trauma Association annual meeting was actually in Vancouver, so where I was training. And I got to see firsthand how research is being implemented, incorporated into people's practice. And I think it's just incredibly rewarding that by conducting research, you're actually improving patient care on a really large scale beyond just your clinical practice. So, of course, as surgeons, we want to provide great care for our patients within our institution, within our clinical practice, but this is a way to kind of improve care almost globally, you could say. And I find that super rewarding.
Pat, how about for you?
Yeah, I do it a little bit just because it's finding an answer at the end of a question that you're really interested in. I don't do the high level research that you two do. I do some kind of small little retrospective studies looking at my little unique practice down here in Houston. And when you get an answer to a question that you really don't know, it's just fun. Like you crunch the numbers and you honestly have no idea what's going to come out, and you get an answer and you say, "Huh, that isn't what I thought," or "It is what I thought." And I find that just super intriguing and fun to do.
Phil, I know you were really excited to enter the touchy-feely portion of the lecture. We're 30 seconds away from it being over, but if you wouldn't mind sharing with us why you do research, I'd appreciate it.
Sure, I think it reflects some of what Pat said, the curiosity, the question that's not answered, that you can think a way to find an answer to that's going to help patients. So much of the studies I participate in are driven by complications, which are frustrating to have those. But there's a way to answer a question to then direct treatment to avoid those complications or outcomes. And I think a lot of the studies that I get excited about are related to that. And then lastly, I love teaching. I love working with our fellows, our residents, and our students. And outside of operating together and seeing patients in the clinic together, this is like the trifecta, is then getting to work on a research project, answer questions, see residents, fellow students who are really talented in this, who are better writers than me. Like that to me is just so fun to work with those folks and see their gifts. And again, trauma is a team sport, and that's why so much of us love it. And research is that too. And so that's the really the third. If I did it alone, it wouldn't be nearly as fun, but it's fun when it's with the group.
That's great. Those are really thoughtful answers. And I just want to point out something that you didn't hear anybody just say that they did research for themselves. Like that never came out. Like I do this for me or for my career or to advance my standing within a society. It was all about a genuine intellectual curiosity, or improving patient care or being part of a team, which sounds like lifting people around you up. And those are really the exact reasons. I would say I couldn't more perfectly summarize the reasons I do research than taking a culmination of the three answers you just heard, which I love identifying a problem and finding the answer. It's like finding the pot of gold at the end of the rainbow, except for you actually get to find the pot of gold because the answer's there. I find that so fun. And then putting that in a way that others can synthesize and use to build and advance their knowledge base is incredibly rewarding. And while I may do 4 surgeries in a day and change the lives for 4 people, I could do a research project that changes care globally and impacts thousands, or dare I even say millions of people on a daily or weekly basis. And that's super awesome. And then finally, it's a way to help me advance the careers of other people around me as they're sort of building their portfolio and honing in on their research skills. Some people do research because it's a job requirement. My chairman needs to say or says I need to do research, or my medical school chair says we all have to have a research project. Or I want to be the person on the podium giving these lectures and I want to be famous, or advance my career so that I can become a full professor. Or maybe it will bring me some level of money because companies will want my ideas because I'm doing all this important research. There are people that do research for these reasons, but while you all are young, impressionable medical students, I would caution you against doing research for these reasons. Because the people that I know that I believe are doing research for these reasons, I think have a research career that is very unfulfilled and it's not very rewarding for them. And because of this, research becomes a job instead of like an enjoyable hobby, which is how I find it. I don't get paid to do research, but I do it because it's like going for a run or going on a fishing trip or something. Like I find legitimate enjoyment in doing it, and not always. Research can absolutely be frustrating and it can feel like extra burden at times. But the end result, ultimately, when I reflect on projects, I usually find reward. So research, another reason to do it is because you like to think, you like to be challenged, and as Phil alluded to so eloquently, team science is a fun thing. It helps others and it makes a definite difference in this world. So now that we've found our why, which is important in many aspects of life, let's just talk about how research influences evidence-based medicine. What is evidence-based medicine and why does it matter? Research, in my mind, is important because it influences evidence-based medicine. And evidence-based medicine helps us protect health and save lives, literally millions at a time. Like the impact of research can be far reaching, like Aresh said. And because of that, it's critically important to advancing the science of medicine and improving the care that we provide. So, to take a line from the book Statistics and Data Management, which can be extraordinarily dry, The key to a successful research project is to translate distinct clinical information into the correct numerical vehicles. So the key to evidence-based practice is then to retranslate that information encoded in numbers into a clinical language. So we're taking a clinical problem, we're making it into numbers essentially that we can analyze, and then we're taking those numbers and making them into the language of medicine that helps us change the care we provide. And if we look way back into the sort of early times and the first examples of clinical medicine, in the mid 1800s, we were still asking the question as to whether or not the practice of washing your hands was a good or a bad thing. So we've been thinking about evidence-based medicine and clinical translation for hundreds, literally, of years now, and we continue to make progress in it every day. So let's talk a little bit more specifically about evidence-based medicine and the different strengths of evidence-based medicine. Aresh, this is a pyramid that I think everybody probably saw in their epidemiology 101 course in undergraduate or perhaps in medical school. Can you walk us through this pyramid, what increasing evidence strength means to you?
So I think what this pyramid shows is kind of differing levels of what we call like internal validity. So whatever the study is trying to demonstrate, how true are the actual results? And as we all know, when we go through retrospective studies or smaller case series, there's a lot of play for just random chance. And so you may not necessarily change an entire practice based off of case series, case reports, retrospective studies, which would be lower down on the strength of evidence. But as we go up towards the randomized control trials and even the systematic review meta-analyses, now we've got higher quality evidence where the internal validity is usually much stronger. And so the results from that, we're more likely to translate that into our clinical practice. I would just say there should also be some caution that not every randomized controlled trial is conducted the same way or with the same rigor. And so that's where kind of understanding research, being engaged with it throughout your education is important so that you can evaluate the studies yourself, how valid are they, and whether you're going to change your practice based off of it.
I think one of the things to point out is that also a lot of teaching kind of goes into, or it's funneled into, that basically randomized control trials and systematic reviews and meta-analyses are all we can really look at. You know, that's the best data that's out there. But honestly, some of the most impactful and influential studies that still drive our practice are case control studies or even case series that are just really well done, really thought out, simple questions. And, you know, a lot of these were run by medical students, or a lot of the data was collected by medical students. They wrote some of it and have really kind of changed practice, being a part of even simple studies. So just because it's not a randomized control trial doesn't mean it can't change practice or answer questions.
I think that's like an excellent point, Pat. And I just want to bring up a very specific example of that, which is a study that medical students interested in orthopedics have definitely heard of or will hear of either at their home sub-I or at visiting sub-Is, which is Dr. Baumgartner, who is an orthopedic traumatologist, study on tip apex distance. So we can kind of have a brief full circle moment here back to our consult at the start of this presentation. Was that unstable intertrochanteric hip fracture that is going to be treated likely with a cephalomedullary nail based on evidence that we're going to review later in this lecture. And where that screw from the cephalomedullary nail lands in the head of the femur is incredibly important. And that whole definition and the importance of where that screw lands was basically devised, understood, and reported on by Dr. Baumgartner when he reported on tip apex distance and hip fractures. And that was in a retrospective review. So essentially a retrospective case series where he showed that having a certain tip apex distance, less than 25 millimeters, proved beneficial for the patients in that they had less screw cut out. And that is a paper that is cited time and time again, that medical students and residents are asked about at every case conference or fracture conference where a hip fracture that gets treated with a cephalomedullary nail is presented. And it's a retrospective study, and it has changed practice, and it's quoted to this day and will continue to be quoted for years to come, right? That is like my favorite example of that. So you as a medical student don't need to seek out an RCT or a meta-analysis. You just need to seek out a mentor that can help you identify the right clinical question. So evidence-based medicine is not knowing necessarily what's best, like it's trying to identify what's best for your patient through evidence, I guess is the best way I can summarize it. And oftentimes you'll hear people compare evidence-based medicine to eminence-based medicine. Eminence-based medicine being, I know what's best for my patients. I've been using this method for many years. But you'll see that there's no real science in that. It's just my own experience, what I do. It may very well be the best, but you don't know that because a scientific method hasn't been applied to what you're doing. It hasn't therefore been tested with scientific rigor. Where evidence-based medicine, instead of saying things like that, will ask questions such as, is this treatment the best available option? Are there any clinical studies investigating the advantages or risks of this treatment, right? And so evidence-based medicine is really a framework for us to think about these problems. And there's a systematic approach to clinical problem solving that involves integrating the best available external evidence, so that would be manuscripts, outside research, mating this with your own personal clinical experience. Okay, so now you've taken evidence, but you've also taken your own expertise, skill set, and experience, combined them, and then use those within the framework of the patient's preferences and circumstances to make a decision about which treatment is best for an individual patient. Now, I know Aresh and Pat have both been working during this week. They've been either in clinic or in OR and likely in both places since it's late in the work week. Aresh, can you think of a patient you've seen throughout the work week this week where you kind of worked through this framework?
Yeah, so I mean, like we were talking about earlier, one of the studies that you're actually leading, Lucas, is this beads versus VAT question that we really don't know the answer to. And so today, one of our patients had an open tibia fracture, and we really didn't know how best to cover the wound. And so maybe I'm not incorporating evidence-based medicine per se, but I'm trying to engage in research to help find that answer. So they were enrolled in your trial, and their wound coverage was randomized. And so that's just kind of a, research is always being performed daily, even in clinical practice, all the time.
Yeah, that's a great example. So Resh is just helping me with a study, and we'll hopefully provide you all with some evidence to incorporate in your practice as you move forward when you're managing severe open tibia fractures. Pat, I think you were in the OR today. Is there any specific anecdote from the operating room you could share with us where you feel like you sort of implemented a evidence-based medicine framework?
Yeah, I'll just briefly say I did a bicondylar tibial plateau fracture today, and I put a posterior medial buttress plate in order to secure a posterior medial fracture fragment that, this is a concept that came about in the early 2000s as plateau fractures were failing. There were higher energy, and we were trying to understand, we as a generic, I had nothing to do with this, but the orthopedic surgeons were trying to figure out why they were failing, and Dr. Higgins and two junior residents wrote up a little case series on the importance of the posterior medial fragment. And just as simple as that, of a little case series, have us change the way that we treat patients. And now all of us understand, recognize, and buttress posterior medial fragments, which have significantly changed the outcome for patients with these fragments and have helped thousands and thousands of patients. And so that's one thing the fellow and I were looking at is how to buttress and why the importance of it. But that's just a simple, there was no randomized control trial about fixing these or not fixing these, and so that's one thing that I did today.
So you hear there again another anecdote of a simple case series retrospective study that has had far-reaching effects and clinical implications. And I can share with you guys a little background about that study, actually, because Thomas Higgins, who's the senior author on that paper Patrick Kellum is referring to, is one of my partners and trained both myself and Pat. And at the same time, he was writing up his series of failures, essentially inability to capture that posteral medial fragment from a lateral based plate. The team at Harborview Medical Center in Seattle was doing the same. And so two papers actually with the same concept came out at around the same time, one authored by Dr. Higgins and one authored by Dave Beret, one of the orthopedic traumatologists at Harborview. And you can imagine the synergy of having two independent centers seeing the same clinical problem, asking the same question, investigating it in the same manner, and then interpreting their results similarly and publishing simultaneous. So those two studies have, as Pat said, really went a long way to change how we treat those injuries. And now reflexively, if Aresh, Pat, myself, or Phil see a bicondylar tibial plateau fracture with posteral medial involvement, we know that that's going to require a posteral medial approach and a buttress plate because of that work, which is incredibly cool. Like, it's hard to put it into words oftentimes, at least for me, how awesome that is. Like that they saw a problem, they investigated it the right way, they came to a conclusion, they disseminated the data by sharing it with us in a journal publication and also presenting it at national meetings, and it has undoubtedly improved the way we treat those patients. So evidence-based medicine is not a cookbook, though. What I mean by that is you should not just read a paper and blindly follow it. That's why if we go back a couple slides, you're really incorporating the evidence with your own experience and the patient's preferences, okay? And you shouldn't use evidence-based medicine to just look for literature that supports your point of view. You should look for the literature, the research on the topic, regardless of which viewpoint it may support, which may very well be a viewpoint different from yours, okay? And you shouldn't just blindly follow the new trends in treatment of injuries or in diagnostic or postoperative protocols. You should make a critical appraisal of all of the available data. And certainly, evidence-based medicine is not a substitute for exercising your clinical expertise. So while I talked about eminence-based medicine, which is I know what's best for my patients, I've been using this methods for many years, I don't want to completely villainize that standpoint because individual surgeon expertise is worth something. It's just not a means of fully excluding the evidence or ignoring it, okay? It's a culmination of things when you're making these decisions. So be selective at each stage when you're trying to find the best available evidence. So you need to know what clinical problem you're dealing with. You need to ask a well-constructed question, acquire the relevant evidence, and appraise the evidence for its validity and relevance to, again, the patient you're wondering about that has a clinical problem. And that allows you to apply the information to the questions. Okay. So you work from a patient with a clinical problem all the way to applying this information back to that patient. So if we're going to talk about how we create evidence-based medicine, and once we've established why we're doing the research, we can start to think about how you execute a well-performed study. And this is one formula or framework to think about that many of you, again, have probably been introduced to at some point, which is a PCOT table. Aresh, can you kind of work us through what this framework is when it comes to clinical research?
Yeah, it's a reproducible way to ask a question very clearly so that you can ideally answer it very clearly. So the patient is obviously kind of your external validity, your generalizability. What is the sample that you actually want to study? There's usually you're comparing two treatments, so your intervention and your comparison group or your control group. And then it's really important when you're doing a study to define your outcomes and your timeline as well. So surgeons or people reading the evidence can kind of interpret how does this going to actually affect the outcomes in your patient population.
Yeah, that's perfect. And if we want to come back to that page we received at the start of this lecture, and we've got an elderly patient with an intertrochanteric femur fracture, the first question I asked was, how soon does surgery need to be performed for this patient? So a way to work through that framework in a PCOT would be the intervention is, let's say, does surgery need to be done within 12 hours? And I'm going to compare that to all surgery done within 48 hours, looking at if that has an impact on a 30-day mortality for these patients, which means you could follow these patients to 30 days, or you could follow them out to even 2 years to see if there were other long-term consequences of having what we would call in this setting early versus delayed or standard intervention. Once you've identified and went through your PCOT, you can move on to acquiring relevant past information. So one thing you don't ever want to do when you're trying to come up with a good research question is duplicate something that's already been done. So it's important to go back and appraise other investigations that have been done in this area, right? And if a study has been done on the topic and even the exact question you're interested in, it doesn't necessarily mean you shouldn't do it, because what you need to do is appraise the quality of that data and see if you can improve upon it. Pat, how have you gotten good or improved your skills when it comes to appraising clinical data or the validity or integrity of a research manuscript?
I mean, I think that's there's a lot of ways I've gotten better over time. Part of that's being a reviewer of articles for journals. Part of that's being a part of some of these bigger clinical trials on certain committees, looking at the methods and the adjudicating the outcomes. But largely, it's just doing more research. It's answering a question, writing the study up, submitting the study, and getting reviews back, and then saying, wow, those are all really good points. Like that I should have done this, I should have done that. This was better design. Let me read about that. And then for every failure, it's kind of like Phil was mentioning about clinical failures. There's not a single one of us up here that doesn't have an entire folder in our computer of failed research projects. That we've all learned maybe more from that from a clinical research standpoint than the ones that actually did get published. So I think just being a part of the process and submitting them and being the point person of doing all that, I've learned so much. That's probably the most number one thing I've learned from.
Aresh, how have you honed those skills?
I think much the same way as Pat has said, and it's about doing the research. So ideally, with somebody, if it's your first time doing research, that's mentoring and guiding you. But I think the best way to learn how to interpret evidence and everything is by doing the research yourself, which is kind of why it's always incorporated into medical school and your residency curriculum as well.
Awesome. So Pat and Aresh, basically, if I'm going to summarize what they said, is experience, the experience of doing it. And I also find, in addition to doing my own research projects and submitting them, that reading or reviewing papers, like Pat said, is incredibly helpful, like formally for a journal, but just reading the research, the content out there allows you to start to synthesize the data, and seeing the strengths of certain studies and the weaknesses can help you both incorporate the strengths into your own research and avoid maybe what would be considered a weak point. So, if you find an area of content that you're interested in, let's pick hip fractures. I mean, there's more literature out there on hip fractures than you can read in a lifetime. But maybe it's one part of hip fractures. Let's say the use of tranexamic acid in hip fractures. Find those papers and read them if you're interested in that topic. It will make you, even if you don't do a research project on that topic, it will make you better at doing research in any realm.
I'll add one thing, Lucas. Yeah, as a student, you're going to have access to like journal clubs and things like that potentially. It's almost always that you'll be invited, to go to it. I think there's such incredible value to hearing other folks' critique of articles or on the other side, praise of an article and its utility potentially. So, especially early on, yeah, absolutely read, if I find an interest in trauma or sports or whatever it is, start reading those types of articles. I think it's hard to put it in context, but then if you go to a journal club and hear an experienced faculty member say, "Hey, I use this every single day," or somebody say, "Wow, this was a big missed opportunity. Here are some of the big weaknesses with it." They've got this huge sample size, but they're not asking an impactful question. It begins framing things in a little bit of a different way. So keep an eye out for that, even if it's not a field you're interested in. Going to a journal club that's in medicine is going to be helpful to you to hear people talk and critically appraise studies.
That's an excellent point, Phil. And I'm going to add to that. If you go to a journal club, read the articles, appraise them yourself, and then allow people that are content experts to appraise them in front of you and see how what you thought of the study matches up to what a quote unquote content expert thinks about it. You know, Pat at his institution, I'm envious of them because I think him and his trauma partners have a journal club once a month. He's sending me a couple times a year an article that I've published and telling me how bad his partners thought it was. So I really miss out on the opportunity to do the same back to him.
That
And I
opportunity
totally
is available for
can't.
any research that's published.
So, yeah, appraising the information is really interpreting the validity and relevance of it and asking about the strengths of the methodology and how the results were interpreted. Is this work generalizable and therefore applicable to my patients? Okay. And then finally, as we talked about earlier, coming up with a well-constructed question, acquiring the relevant evidence, appraising it, and then you can apply this information to your patient. That's how you work through evidence-based medicine, which will keep you up to date on the latest medical information, serve as an objective way to determine and maintain high quality safety standards in your medical practice, and speed up the process of transferring clinical research findings into practice. So it really will guide you in your decision making. That's why evidence-based medicine is important, and it helps you establish and maintain a high standard of practice for your patients. Honestly, in some ways, evidence-based medicine is a way of holding yourself accountable and being up to date in the best treatment methods for your patients. So know how to search for information well, how to read and think critically. And Phil gave you guys a great way to practice that, which is going into journal clubs. You can identify gaps in your knowledge, open your mind to alternative treatment modalities, and transfer your knowledge. It will support career opportunities. Practicing evidence-based medicine will support career opportunities because it will make you a better physician clinically, but it will also help you identify research opportunities and therefore improve your research skills. Okay. So the take-home messages with evidence-based medicine is that it's integral in clinical decision making. It has the potential to change clinical practice. Make sure you're acquiring appropriate information, appraising it critically, and then applying it when relevant to your patients. Okay. So our full circle moment of the night brings us back to our consult. And I know the medical students, you're like, we're 50 minutes into this lecture, and you haven't said the words exactly how I'm going to be successful doing research. And I have good news for you. Dr. Kellum, Pat, is going to tell you how to be successful in about 3 minutes. The bad news is it's mostly common sense stuff about how you can be successful, but Pat's really going to outline it for you after we talk about this. So bringing it back to our 71-year-old female on apixaban. She had a ground level fall, as you'll recall, this intertrochanteric femur fracture of her right hip with a history of heart failure. And we asked ourselves, how soon does surgery need to be performed? Turns out sooner is better, and we have a lot of data to support that. What do I do about that Pixaban? Turns out nothing. You're going to operate right through it. Does the patient need an echocardiogram? Maybe. It may delay care, but it also may provide the anesthesiologist with some important information, and you can make that decision by searching the relevant information and discussing it with your anesthesiologist. Should this patient receive a general or a spinal? Good news for you again. There's two really high quality RCTs on this topic, which show a general anesthetic is just fine for these people. Despite a push several years ago to move towards spinal anesthetic for hip fractures, turns out general is probably okay. What medication should the patient receive intraoperatively? Antibiotics is one of them. What about the use of intraoperative TXA to decrease blood loss? Well, that's a topic that's been studied to no end to date, and there are even systematic reviews and meta-analyses on that topic and things that I would encourage you to review. What skin prep solution should I use to prep the surgical site for my patient? Thankfully, there was recently like a 12,000 patient RCT published on this data that helped demonstrate that DuraPrep is better than ChloraPrep, those being the two most common used prep solutions in North America. What bed should I use? You could use a flat top or a traction table. They both have benefits and drawbacks, and those have been well outlined in the literature. What implant's best for this injury? Should this again be a DHS or a cephalomedullary screw? We know, based on a litany of work and multiple publications from different institutions, that cephalomedullary nails for unstable patterns probably do better for our patients. And finally, a question as simple as how do I close this wound is something that has been identified and outlined in the literature. And I want to point out something that Pat brought to my attention when we were going over this presentation, which is medical students have played a role in many of the studies I've just outlined in the treatment pathway for hip fractures. They've played a critical role in collecting, appraising, and disseminating this information. And the next generation of medical students is you all. And because of that, I would encourage you all to be involved in research. But really, I want you all to find a why. I hope that why is not for you to become famous or for you to get a spot in residency, but out of a genuine intellectual curiosity or out of a desire to help others. I hope you find your why. Hopefully, I've taught you a little bit about what evidence-based medicine is and why it matters in clinical practice and in the day-to-day lives of surgeons and medical practitioners throughout the world. And with that, we can talk a little bit about how you can succeed at performing research as a medical student. I'll turn it over to Pat for this slide.
Yeah, I think Lucas mentioned it a little bit earlier. We've gotten 52 minutes into this presentation. We haven't given you any specific keys on how to succeed, but I think we actually gave you all of the keys to succeed. If you think about all the topics that Lucas talked about, if you have a why and you understand what research is, some people don't get exposed to clinical research. They think it's bench research. They think it's pipettes or rats, and they don't know that there's clinical research out there. And the amount of impact that you can have as a medical student, if you just have a question that you're curious about, why are we doing this? Why do medical students, why is your medical education changed? That's, a lot of us sat in lectures, and I think now most of the medical education is small groups and other things. So even simple questions that relate to medical students, how do I get better anatomy knowledge? It seems like I don't know my anatomy as well as my attendings want me to know. These are all things you can ask questions to and do research studies on. So the why of why it's important and the why of why do we do it is really what can drive you to succeed. But there are a couple points. This slide looks awfully like what we talked about in our first session of how to succeed as a medical student on your rotation. It's not altogether too different of how to succeed in doing research. The biggest thing is have an interest. That was what the first 50 minutes of the presentation was for. Have an interest of what you want to look at. If you have zero interest in spine surgery, joining the spine surgery research program is probably not going to get you anywhere far in your research career or as a medical student, because you're going to lose interest. You're not going to want to do it after you've been studying for your shelf exams. You want to have something that really piques your interest, so that you can take the time. Because a lot of us, even I'm sure everyone on this call does research. They're going to do some research after this call tonight. They're going to do it on the weekend. It does take up our time. And that's the same for the medical students. So if you don't have an interest in it, then it's never going to happen. So don't join something you don't have an interest in. Find a mentor. That mentor can be a medical student that's above you. It could be a resident. It could be an attending. Find someone that you identify with that's doing what you want to do. They seem to be publishing a lot. They seem to be doing a project that you like. They seem to be doing this. They seem to be doing that. And this really interests you. All of us have these people in our career that we had at each stage. We had medical students that we looked up to, we had residents we looked up to, and we had attendings we looked up to. And you can find multiple mentors, but that's a super important thing to have, so that you can continue to raise the bar, and you can start to mold yourself like that person that you want to be like. Work hard. This is the same thing as the first session. You have to meet the deadlines. People have certain things. If we give you a deadline to get a project or data collection done, you need to do 10 of these patients by next week. You need to get 10 of those done by next week. If you don't do that by next week, then people start to lose confidence that you can complete the task in the certain amount of time that we're given. And so just make sure you're working hard and meeting the deadlines. And sometimes that means a little bit of a late night, but we've all been there. Advocate for yourself. If you're sending emails, or you feel like you sent an email 2 weeks ago and that's enough time for you to get a response from somebody, send another email, set up a meeting, make a phone call. These are all things to advocate for yourself to get projects done. Don't just send the email and then forget about it and stew over why the attending hasn't emailed you back in 3 weeks. It's probably because their email got 20 other emails right after it, and then it just kind of slipped their mind or something. So advocate for yourself. And then as you start to get good at this, seek more opportunities so you can get more experience like we talked about earlier. So if we go to the next slide, these are all research projects that Lucas, Suresh, and I did when we were not residents. We were medical students or undergrads. So Aresh, can you talk a little bit in the last couple minutes? What were the kind of the big take-home points that you got this done as a medical student, as an undergrad? What was it that you got this project across the finish line that the medical students can take home?
Yeah, I think obviously the systematic review was actually not even in orthopedics. It was at a time where I wasn't quite sure what specialty I wanted to apply to. I think it really just emphasizes that quality research is quality research. And so even if it may not be in the exact topic you want or in the exact field you want, I think working hard, hitting your deadlines. I was working with a cardiac surgeon at the time and pushing it through. It was a very good learning experience for me. So I'll say whatever you take on, just make sure you push it through the finish line and try and learn all you can from it, even though in this case it may not have been in my specialty of choice now that I'm an orthopedic surgeon.
Dr. Marchand, do you have anything about this? This was, I think, as an undergraduate.
This was actually between first and second year of medical school, Pat. I had done some research as an undergrad, but this was my first PubMedable publication. And it was really just an opportunity to learn how to do research. My medical school would support you if you could find a mentor through a research project between first and second year. And I really wanted to learn about research and how to do it. And so I did something that's sort of peripherally related to medicine, was a benchtop research project that taught me a lot. And it really, I'm grateful. I think it's cool that you showed this publication to everybody, because I'm not known for it, nor could I probably quote all of the conclusions of the study. But this was the beginning of my research career, and this publication really means a lot to me, taught me a lot, and was the foundation of everything I've done since then. So it's kind of cool. And just find something that you're interested in. I thought this was a super cool project, which is why I sought it out and got support for it. And then my research career has turned into what it is now, which is cool.
Dr. Mitchell, anything your points from being a medical student doing successful research?
No, I think I'd add, so work hard. And then there are going to be opportunities to go above and beyond, and that can often be an indication of a workhorse. And then you can get a reputation as a student, and then suddenly you find yourself helping with multiple projects of varying levels of impact and then varying study types. And so I do think, still think of it as an educational process as you get involved in a systematic review, and then you're helping on a retrospective study, and then you're helping on a case report, and suddenly you're involved in all of these different types of research and uh, getting education while pushing the field, while doing something good for your future career. So I'd say if somebody tells you to write an introduction, yeah, write the introduction and then start working on the method and say, I did the intro, but I also drafted a method section too, and I'd really appreciate your feedback on that as well. So hit the deadline, but it is okay to go above and beyond. Oh yeah, you said do 100. I did 200 patients. I hope that's okay. I hope I didn't step on anybody's toes by doing that. Um, so I'd say that. And then just on that last point, it's a team sport. You may be working with other medical students. You'll be working with residents. And so teamwork is such a huge part of residency as well. And so your ability to collaborate and work well with others, often those skills are shown in the research space. So early on, we can identify that this person is a great team player who's always giving credit to those around them and is always trying to help out and, not be in the limelight. And those people end up being incredible residents because they end up trying to help their residents, their co-residents, very ethical people who are making excellent decisions. So some of that you see in the research realm. So it's your first opportunity to kind of show what kind of person you are. And so I'd add that as well.
Yeah, so I think that's perfect. Yeah, go above and beyond. That never is going to hurt you anywhere in life, and especially in research and orthopedics. But I think you see two of these were systematic reviews. They're all just simple things you can do. I did this with there was two authors of us, and I did most of the heavy lifting for this, and it was just something that was interesting. You get done, and you get done kind of almost in a weekend. That was not that hard to do, finding gaps in the literature and then doing this. So work hard, find a mentor, and you'll and find an interest. I think that's all the things that Aresh and Phil and Lucas said. These projects were the same thing. They found a mentor, they had an interest, and they worked hard. If you do those three things, that'll get you through research, and the education for research comes with it when you do it a lot. So hopefully we taught you today of why research, why do we do research, why is it important, and what is your why do you want to do research and to try to start and stimulate your interest in picking a project. Touch base on a little bit of evidence-based medicine and why it matters, how it's not only research, it's advancing clinical care as well as your own education and shaping what you know with what you don't know in order to help better treat patients. And then how can you succeed in doing research, finding an interest, making sure you work hard, and finding a mentor. So that concludes today's session. Hopefully you guys learned something. I know it was a little less clinical in terms of x-rays, but hopefully helpful for you guys to know a little bit more about research and why you do it and how you can succeed. We're through 4. We got 6 more. Next one is going to be the resident interview sessions. We'll have some important people on here, have a little panel, have also do a little talking about some points that kind of pitfalls, things that all of us have seen in medical students that don't go over well, and then ways that you can shine. And then the best thing for this session is going to be asking questions. So if y'all are on this call or you listen to it later, bring your questions for what you want to know from people that are involved intimately in picking residents and residency interviews. So that'd be November 13th. And then thank you guys for listening. Make sure you check in, because if you do all 10, there might be a special surprise for you. And we'll see you next month. And we'd like to really thank Dr. Mitchell and Dr. Sefri for coming. That was awesome. Thank you for your time. We really appreciate it.